The second speaker is Therese van Amersfoort. Teresa van Amersfoort is a professor of transitional psychiatry and consultant psychiatrist at Maastricht University Medical Center and a visiting professor at King's College in London. Her work focused on the biological determinants of brain development and how this results in mental health problems. She made use of several neuroimaging modalities and unique human genetic models. The titles of the intervention is The Brain in Transition. Thank you, Therese.
Thank you very much. We continue with the Dutch connection, but I make a drastic movement to biology, so I hope after lunch this is still digestible. When Jim van Os and Maastricht University asked me a couple of years ago for this chair in transitional psychiatry, we couldn't imagine what an emergent this field would bring. So now with hindsight, it's really a perfect timing. And I'm also very pleased and would like to thank Giovanni and the organizers to giving me the opportunity to speak here. Transitional psychiatry. I've been asked several times, what the hell is this? And it's been discussed several times this morning. Actually, it's providing a bridge between child and adolescent psychiatry and adult psychiatry. And apparently, this bridge is necessary because there's a huge gap. And in my role over the last few years, I've tried to build this bridge. I've also been creating awareness and touring around the country, telling Swaran Singh's story and Pat McGorry's story, actually, because that's what it is, open the eyes of the Dutch people. And fortunately, they are opening, except for the Dutch government, because they are preventing building our bridges. Yes, I added this sentence because I know there are people from the Dutch government here. And as the previous speaker said already, from the 1st of January, the government are taking away the funding from the healthcare insurances, so they're all going to go to the local government. That means that the gap between child and adolescent psychiatry and adult psychiatry is going to increase, and we're all extremely worried about this. We have 2 weeks to go, and then we have no idea what's going to happen. Having said that, last week we had our first Dutch transitional psychiatry symposium. And it was a huge success, and despite all the measurements taken by our country, we're still telling our story and hoping that they will follow us one day. So now I'm going to move to the biology. This was a statement I just wanted to make. If you talk about the gap, we're talking about a period around 18 years old. Because in Holland, as in many other countries, this gap is actually decided by the fact that at the age of 18 years, most people are legally adults. That doesn't mean there are adult people, but legally they are adult and supposed to, well, function as an independent person. That has consequences for the organization. As we've discussed already this morning, I'm not going to talk about it. But this afternoon, one of our pilot studies in the area of Maastricht, we will discuss the experience of child and adolescents who were transferred to the adult services. It also involved clinical knowledge between the two services. There's a gap there, but also a scientific gap, because the age of 18, it also means that research, both clinical research and fundamental research, is also divided, and that hampers our knowledge. For example, clinical trials, a lot of children or adolescents are excluded from that in the development of medicine. If, for example, a young person with psychosis enters camps at the age of 17, he will probably get different medication than when a young person at the age of 18 enters the adult mental health services. Imaging research, that's mechanistic research. Usually, at least in Holland, the IRB procedures for people under 18 are different than the IRB procedures for people over 18. implying that those group is also divided, the whole group, in two groups. And it means that a group of child and adolescents who enter an imaging study has a mean age of 14, and a group of over 18 that enter an MR study has a mean age of 25. So the group of 18-25 that we wish to study is underrepresented. Talking about PET and SPET, that are very delicate, invasive studies, is basically forbidden in Holland under 18. And I think in many other countries, there's hardly any studies. Whereas these studies can inform us about the development of neurotransmitter systems across adolescence. We have no knowledge, other than from animal studies, on the neurotransmitter systems during adolescence. Epidemiology studies, I'm not an epidemiologist, but in Holland we have this huge cohort called Nemesis. And that starts over 18. And just last week I happened to be a PhD examiner for a candidate who presented data on early psychotic symptoms from the Nemesis study with a mean age of 40 years, because there was no attrition between the age of 18 and 25, because they didn't respond. So the group we are actually interested in, 18 to 25, is underrepresented in scientific research. Well, this picture is probably the most shown picture of this whole conference. But anyway, it clearly shows us that we really need to focus also fundamental research in this area. There's a gap around the age of 18, and we have a lack of knowledge what happens in that period. And there's a need for continuity. So this picture has also been there, but why do many psychiatric disorders emerge during adolescence and not earlier in life or later in life? And for that, we have to understand, I mean, if you have a problem, you first need to understand the problem before you find a solution. So we know now that the development of psychiatric disorder is a complex interplay, which has been discussed this morning already, from several factors, some of which are genetic, that you're born with, the genetic hardware, many environmental factors, including stress, trauma, cannabis. But the combination of these two affect also brain development and neurotransmission. And the last two I'm going to talk about. Adolescence is a risky period. It's a peak of physical robustness. You know, you're physically at the strongest period of your life. However, there's still an elevated risk of death and injury. And alcohol, drugs, and suicide are major causes of death in young people. There is a relation of brain development and behavioral change. And I'm going to show more about that in a second. But in Holland, the Dutch Brain Foundation did a survey amongst parents. And it was very unknown. By a lot of lay people have no clue that there's a relation between brain development and their naughty son or daughter. And so there's more awareness necessary there and more education. I find myself that it really helps sometimes if I'm in a clinic with parents and their adolescent kids, that if you explain how the system works, the brain and the neurotransmitter systems, they are happy to have that knowledge. And also nowadays they look it up on the internet anyway. And you're not sure if they get the right information then, so you might as well explain it properly. So the adolescent brain is a brain in transition. And it means there are a lot of structural changes happening, affecting gray matter, the gray cells in the cortex that are pruned. It's a pre-programmed process. And it's, at the same time, myelination occurs, which is the link between the gray matter. It's like a road map connecting the gray matter islands. Functional changes take place. There's an increase in connectivity, meaning an increase in efficiency of the brain, and neurotransmitter systems change. If you go to look at the brain development since birth and preconception, you see that it's a dynamic process which starts after conception with the formation of the neural tube, the neuronal proliferation, and actually pre-birth the number of neurons are formed and stay equal. But then the neurons migrate, and we all know that pregnancy is a delicate process and you have to be careful with your diet and everything you do because brain development is delicate. But it doesn't stop after birth. after birth, there's an increase in connections between the neurons called synaptogenesis. And during adolescence, continuing into adulthood until the age of 25 and 32 years old, myelination is still taking place. Apoptosis is the pre-programmed cell death. That's also taking place. This is a natural process, but this is to illustrate that it doesn't stop after birth. The synaptogenesis, meaning the connection between the neurons by the formation of dendrites, actually at its peak, which is in infancy and childhood, includes the formation of 8.1 million synapses per second. By the age of 16, these synapses have reduced by 50%. And during adolescence, you lose 20 billion synapses per day. This is just to illustrate how dynamic it is in the brain. So these gray cells, at birth, they are the gray cells that are touching each other here and there a little bit. But during childhood, these connections are getting very tight, and that goes in a gradual process, starting with the sensory areas, like the occipital cortex. But during adolescence, these connections loosen again. So the amount of neurons are roughly the same, but it's the connections between the neurons that is dynamically changing across childhood and adolescence. And in line with that, you see the connections of the sensory pathways are the first one to be hyperconnected and also to be pruned, followed by the language areas and followed by the higher cognitive function areas, lastly, the frontal cortex. So also there, it's a gradual process that happens in stages. One of the hypotheses is, with regard to the development of psychopathology, is that this pruning process is actually getting wrong somewhere during adolescence. So the idea is that this is the normal development, that, for example, in people with psychosis, there's an excessive pruning during adolescence, and that in that reason the connectivity is disturbed. With autism, we know that children with autism have higher volumes of brain. The hypothesis is that they have too many connections. There are too many connections with the neurons, and that they're very sensitive for stimuli, external stimuli. And of course, with Alzheimer's disease, this happens late in life. So to sum up, the transition in brain during adolescence, because of the pruning process, there's a reduction in gray matter volume of approximately 15%, and at the same time an increase of white matter volume, which is caused by the myelination. This is a fatty sheet that forms around the axon of the neuron and increases the efficiency. So you don't need all these connections anymore. But this is nicely synchronized. However, there are a lot of factors like trauma, stress, but also drugs that can interrupt this process and cause irreversible damage. The pruning process, by the way, goes according to the principle use it or lose it. So if you don't talk, you don't use language, the connections get lost there. Gender differences. We haven't talked about it this morning, but it's very important to realize that there are gender differences in the brain development, but also in psychopathology, we've heard. Boys are much more difficult to get into the picture, and also as we look at the figures from the mental health care consumptions, they drop out easily in adolescence. So as you can see, the white matter volume, as predicted, increases over time in the women and much steeper in the men. So this is the volume of white matter. However, the myelin, the fatty sheet, increases parallel in the women according to the volume, but declines in the men. And that might be because the axon fibers are maybe thicker in diameter. This is just to illustrate that there are also gender differences in brain development, and I think we should also pay more attention in the whole approach of mental health disorders in youth to the gender differences that we observe also in our clinic. I'm a biological researcher, but I'm also a clinician. So net, the total brain volume stays roughly the same. It's the white matter volume that gradually increases until the age of 30. This is still ongoing, the green bars. Gray matter declines, red bars, but net, it's mainly blue bars, stays roughly the same. So that's why we previously, before we had all these fancy imaging techniques, we always thought that the brain was ready at the age of 5 because the volume of brain at the age of 5 is already almost approximately the adult size. Well, the frontal cortex, that's what it's all about, of course. Not all, but a lot is about that. That's the region that lastly develops. The more blue you see, the more gray matter reduction because of the pruning process, which means the maturation is complete. So as you see, the development, the maturation starts and goes gradually and is last ready in the frontal lobe. Is that bad? Well, the frontal lobe is our CEO. It's the chief executive organ, which is involved in planning, attention, concentration, but also impulse control, emotional control. It's the controlling function. It's the brake of the brain. So what is happening, and we saw this picture already by George Patton in a different graph, is that there's a mismatch during adolescence between impulse regulation or impulse control and the sensitivity for emotional stimuli. If you look here, this is the frontal cortex. This is the impulse regulation area that develops slowly. This is child, oh, it's a poor quality, child, adolescent, and adult. So that develops slowly. Whereas the emotional area, the limbic system, that is involved in reward and sensitivity for emotional stimuli, peaks during adolescence and is much smaller in both children and adults. So, while there's insufficient impulse control, the youth are hypersensitive for external stimuli and for immediate reward. They can't prolong the reward, it has to happen now. Whereas adults are actually already having pleasure in the anticipation of reward. So the immediate reward is a very adolescent-specific thing. And this study shows another way of providing the same message, actually. This is a study where the subjects were asked to look at neutral phases, calm phases, and happy phases. And they had to press the go button when they saw neutral phases, and the don't go withheld the response when they saw the happy phase. And as you can see, the adolescents were making more mistakes at the happy phases. They couldn't withhold it. They were unable to resist the emotional stimuli. You see also a larger activity. So there is a specific characteristic of the adolescent that is very much distracted and tempted, can't resist the temptation because of this mismatch between impulse control and emotional regulation. And it's been thought that it's caused by dopamine. And also the dopamine system is hypersensitive during adolescence. Although this is mainly coming from animal studies, but it seems that during adolescence the dopaminergic receptors are highly sensitive more than during the childhood and adulthood. And this is one study we did where we looked at the effect of dopamine depletion on reward modulation. And if you take away all the whole dopamine system after a depletion challenge, there is no activity anymore in brain during a reward processing task. One of the other, dopamine is the most studied neurotransmitter system also in psychotic research. And as we've heard this morning already a few times by George and by Pat McGorry, that there's been a lot of research on the prodromal or the high-risk states of psychosis and the transition to psychosis. And one of the more robust findings, I mean, there are many imaging findings that are controversial, but this is one of the more robust findings, is that those young people that are at high risk of psychosis have an increased striatal dopamine release, those that do go on to develop psychosis. And that has been replicated now in an independent sample. And also 2 other groups, including our own, have found that there's an in striatal dopamine in young people at high risk states to develop psychosis, and that is related to positive symptoms. Then the effects of alcohol and drugs. What is very important is the timing, and also that I think this morning somebody said, but it really makes a difference if you start to use cannabis or ecstasy or alcohol at the age of 15 or at the age of 25. And as this paper said, it's worth the wait And these results show that the younger you start with cannabis use, the worse the quality of your white matter integrity. Fa is an index of white matter integrity is. And also the more impulsive you are. So the later you start with marijuana, the less your white matter is affected. And the more chance it has to undergo a normal brain development. Alcohol is a similar story. If you start at a young age, then it increases the pruning process in such a way that it hasn't had the chance to lead to proper frontal cortex development. So also there, the younger you start with the alcohol, the more damage to your brain. And this is some of the things that our local government has done, which I'm happy with, is that they have increased the age of alcohol consumption or ability to buy the alcohol. And that's because of this discussion. Ecstasy is a similar story. The younger age you are using ecstasy, the more it affects the serotonin system. Ecstasy works on the serotonin system, and the more sensitive the serotonin system gets. So also here, it is really evident that the adolescent brain is very vulnerable and can lead to irreversible damage. One other interesting thing is that from a study, it came out that adolescents don't learn from bad news. So that it's really important to how you convey the message, and it's a similar thing with this reward story. It has to be brought in a positive way, and then they're able to act on it. Once you bring a message in a negative or automatic way, it doesn't really stick. So this might be interesting in designing new campaigns or dealing with your young people or trying to get them into services, instead of saying what you're doing is bad or this is bad for you, this or do this. And you should change maybe the strategy and change the word around. If you don't drink alcohol, it would be really, really good for your brain, instead of saying alcohol use is very bad for you. So, to conclude, the brain development is a dynamic process that never stops, also not after birth, and it is particularly vulnerable during adolescence, at the time that youth are getting out and about, discovering the world, and getting into all kinds of experiments. There are gender differences, I think, that we address not enough, and I think in general in research gender differences are not addressed enough, but particularly in this phase of life also. And the maturation continues till at least 25 years, so that's an extra argument to provide these services and provide continuity for you young people until the age of at least 25. And yes, then is another big question: when is it normal adolescence, and when is it mental illness? And that's something that we need more research. And I think there are a lot of epidemiologists and people who don't believe maybe in biological and fundamental research, but I think we need to have a mechanistic understanding in order to find also tools to deal with the problem. So I would stop it here, and thank you for your attention.
Thank you for this presentation, stimulating. We have the time for some questions.
All right, it's not. Okay, thank you very much for this very interesting presentation on these developmental issues. Do you have any data or any idea of the effect of psychostimulants used for ADHD on these maturational processes?
I was expecting this question, actually. It's a very good question, and there isn't any data yet, but I do know that there's at the moment in Amsterdam a study going on exactly investigating this. looking at the effect of stimulants on people with ADHD who haven't been treating yet. And they are put in a brain scanner, they get an MRI scan, then they are put on a trial, and placebo-controlled trial, with either placebo or stimulants, and then they get a scanning session again. So the results are not there yet. It's called the EPOD study, but it's on its way. So what the effect, and that study is especially designed because of the discussion about, of course, the stimulants in the brain, and also that's a worry of many parents. And also because we want to know what it exactly does on the brain. And that study looks at two groups. It looks at the adolescents below the age of 18, but also at adults above the age of 23. So also looking at two different phases of life. Yeah. So maybe next year.
Teresa, thank you very much. Very interesting stuff. I was fascinated by this idea that we actually need to give messages in a different way to this age group. Can I ask you to sort of say a little bit more about what the implications may be for the way in which we deliver our services to this age group? What we learned about, because we know that this is an age group which we heard from the previous speaker, they're not accessing services. So how do we configure our services to get better access, given our understandings now of cognitive and brain development?
Yeah, well, I think you've discussed it also. It is a big problem, and I see that also because the people I see are all between 16 and 25 years old, and it's very difficult to keep them in services, and you need to be so flexible with all your availability to be able to get their attention. Yeah, you need to be able to seduce them with something. Yeah, that's what it is. Because it's true also what we know from the brain development, as if they hear if you press the right button, they are willing to engage, I think. But what exactly that button is, that's what I haven't figured out yet. But it's definitely not the tone of adults and our doctor-like attitude or teacher-like attitude. It's not the attitude of you should do this and don't do that. We need to be able to find the release button so they come.
Therese, in Italy, prescription of psychotropic drugs to adolescents is very limited as compared to other countries like the States or even some European countries. I wonder, although I'm perfectly aware of the differences between different medications and different biochemical pathways involved in the mechanisms of these different medications, but from your picture, can you extract a few lessons about the best way to use medication during a very sensible period of brain development?
Well, a common sense is that rather not, only if absolutely necessary, and then as low dose as possible, which is usually, for me, a much lower dose than I would use in adults. But sometimes it is. I realize that it really helps during a temporary period to give them an SSRI or to give them a low-dose antipsychotics, and the benefit they get from that is worth then so much more than all at that moment the potential hazard. And the problem is what I said also. There's very limited research on youngsters, what drugs do on brain development. For example, PET and SPET, which are invasive tools, I understand there are ethical considerations, but they're also beautiful tools to examine what it does to the brain. And we lack a lot of knowledge what happens to the brain with drugs. And in adult literature, there's loads of research on that. The effects of all kind of drugs, pharmacological challenges. That's all that we can experiment in adults, but in adolescents there's very little on it, so a lot we don't know. It might well be that it's not as bad as we think it is, the effect of drugs on brain. I mean, I'm talking about pharmaceutical drugs, not street drugs. Not street drugs, no.
Okay. Last question.
Thank you very much for two great presentations. My name is Dieter Volk from Warwick. I just wanted to ask a question, because the question is always about how should they access services, or should they get services? To put the cat among the pigeons, do we actually know that services are good for the adolescents? We always assume it's good, but you have just said that we have so little research, we actually don't have a clue whether it works. It does work for some, which have got the most severe conditions. Prevention might work while the brain is changing, as was presented in the first, but sending them to services and putting them on waiting lists, at least in Great Britain, for a long time, I'm not sure whether it works. So I think I would start with the first question rather than asking for services to evaluate whether they actually work.
No, I think very good point, and I think I would agree with you that the service we are providing, it sounds similar like the ones we are doing, they're not youth friendly, and they're not, if somebody has to wait on the waiting list, he can't wait that long. That's exactly one of the problems also what happens in the brain. It needs to happen now. They can't wait a month or 2 months. They now have that problem, and tomorrow it might be over again. And that's what I also see when the youth are coming. It's a storm, and the next day the storm is over, and 2 weeks later the storm is back again. So I think, inspired by Pat McGorry's and your story about the service in Australia, this very, whether you call it service or whatever, it's a matter of definition, but some place that people who are in trouble or have a problem at that moment can talk or communicate, can get it off their chest and are listened to. And from my point of view, it doesn't always need to be a psychiatrist, but it needs some form of help if they feel suicidal. And how that is formed, I mean, our services are also not sufficient in that, I think.
Good. Thank you very much.